Okay.
With me is Dr. Sri Krishna and Dr. Daya Vaswani, and Dr. Nihant on this case today. So my patient is a 74-year-old male who had an unstable angina. I think it's non-QMI. So during which time, both LCX and RCA lesions were identified, and LCX was around 80-90% lesion, and that was treated, and RCA was CTO then. So, and that's the reason patient is here today. And ECG, there was changes, and echo, there is audible in inferior territory, and those are the risk scores. Next slide. You can see this is an echo. So yeah, next. Yeah, this is the echo. You can see hypokinesia of inferior wall, still preserved myocardium. Next. And overall LV is kind of mild to moderate LV dysfunction. So next slide, please. Yeah, this was the angiogram during the index procedure. You can see RCA is filling retrogradely. Next, click next. Yeah, so RCA is filling retrogradely, and LCX is showing tight lesion. And you can also see RCA filling from a lady. Play, please. Yeah. Yeah, you can see RCA is filling retrogradely. Next. Yeah, just play. Yeah. So you can see RCA is total occlusion. Also, origin is a bit abnormal, and it's kind of ambiguous cap here. Next. Yeah, so this LCX was done during index presentation. So next, click next. Yeah. So this is LCX result, which is pretty good. Go next. And this is, for today's analysis, you can see this is the proximal cap, which is quite ambiguous. We can see both in fluoro, and I gave even your CT images, which you can make out. There are two branches coming off the proximal cap, and there is one branch coming off, distal cap, which you can see there. And CTO length is kind of 18 millimeters, and there is no calcium, in the CTO, which you can clearly notice. So next slide. Next slide, please. So this is, there is no angulation within the CTO segment. You can also notice that in CT. Next slide. And just press, let the image play. Click, please. Click. Press next. So press next. Yeah, play the video, please. So you can see origin of RCA is above the sinus. In CT also, you can see it is coming above the sinus. So that's the reason we were a bit skeptical about the support in this case. Anyway, we took AL. Next. So, and this is one thing which we did, it's a fluoroscopic view for proximal cap wiring. So if at all, IVOS-guided cap puncture doesn't work. So in this view, both branches are separated, and RCA is coming right in the middle. So we thought of using this view for proximal cap wiring. So we tried. We'll show you what happened. Next. Again, same thing, fluoroscopic view for proximal cap wiring. See, while rotating, you can identify the spot where both branches are getting separated from your RCA axis. So that is what I'm doing. It was like RAO, kind of 50 to 60 RAO and around 20 cranial. So this is where both branches are clearly separated from the proximal cap. Next. But however, you won't get that 3D image of the location of the proximal cap. It's only based on this we can identify. So we have good interventional collaterals. Click. Next, click. Yeah, that's one collateral which we spotted. Another click, please. This was another collateral, so which are quite good. Subtle collaterals. Next. And these are the J channel scores for both collaterals. One is 0, another is 1. And next. And this is the donor vessel. This is, we can even see the lumen areas in CT. We have a good lumen area at the lesion. So almost like 5 square. In CT, though it is not accurate, this became our habit to calculate, every time we do cases. Often, it coincides even with IVUS lumen areas. Next. So donor vessel disease is there, but not significant. So coming to the wiring strategy, obviously it is an ambiguous cap, and there are good interventional collaterals, and there is some support issues, anticipated for RCA. My first choice was, IVUS guided cap puncture, but if I look at both the branches are almost looking like nearly 70 to 90 degrees from the main RCA. That is one negative. So for IVUS guided cap puncture, because the visibility is not great. Next. So if that doesn't work out, I'll go retrograde and retrograde cap. So when I go retrograde, so this is one thing, there is a branch even at the distal cap, probably that can trouble. The only savior is entire CTO is non-calcified. I think that's the savior in this case. Next. Yeah. So this is the case. Probably, Chair can discuss, and or I'll show what I've done.
Sharath, we'll pause you a bit. We'll have a discussion here on the stage, and then.
Yes. Please go ahead.
Maybe for the discussion, show us the first simultaneous shot. Because sometimes
I'll show you,
the artery looks different from the single diagnostic shots.
Yes.
I hope you did one.
Yes. I strictly follow your guidelines, sir. This one, run thumbnail. Yeah. So, yes. So this is the dual injection. You can see in LAO, and as already CT showed us, CTO length is definitely not huge. But proximal cap is ambiguous, and this is the image, which in the view which CT gave. We can see, both the branches of at the proximal cap, going exactly in opposite way, and RCA is in the middle. So these are the two dual injection views which we took. The second one, this one is based on the CT we decided.
And importantly, what you show here is simultaneous injection doesn't mean simultaneous injection, but waiting until the filling of the distal retrograde comes and then antegrade, because sometimes we see really.
The first picture of dual injection, you took the antegrade first and then you injected the retrograde. So can you show it again, Sharath? The first dual injection?
So, okay. Yeah, this is a dual injection.
Here you injected the antegrade first. We would like you to inject the retrograde first. Wait. The
antegrade I injected a little bit early. So actually retrograde only injected first. Antegrade, I injected a little early. The moment distal RCA was filled, I injected, but
it's good. It's a teaching point
for,
and also to wait. We see that it takes 3 seconds.
Yes.
Or 3 heartbeats to get to the distal. So always the large lumen injection into the donor vessel makes the CTO shorter. But you had a perfect workup of the case, and let's get some 2-3 opinions of how to approach. Antegrade first?
I think I was guided antegrade, but I think the side branches are not very optimal for the vessel I was guided.
So maybe integrate first, then go for it.
Yeah.
No need.
I think it's always looking at the complications that are associated with the retrograde. You can always fall back upon, but always can surf one, probably 5 minutes. If you can, it's a great success. Otherwise, you can fall back. I would have probably tried antegrade first.
So give me
the retrograde first, and the retrograde first.
With contrast, please.
I think the first point that I would like to make is that very positive use of the CT angiogram to delineate the anatomy, identify the proximal cap, and identify a proper view for attempting the proximal cap antegradely. That was a great demonstration. The CT, IVUS was not. Antegrade first.
I agree too, because
all right.
doing and preparing the antegrade is very important, even in a retrograde approach. So I would initially try an antegrade, but I was guided.
I would like to evaluate the proximal cap with an IVUS. May not be successful, but at least I want to see the proximal cap with an intravascular image.
So you are already here in the retrograde mode.
Shall I show what I have done? Please, CO03, keep it ready.
I would a little bit disagree with your opinion then that this is not ideal for antegrade IVUS. Other than if it's retroflected, the IVUS will go. But you should not use a short tip
plain RO.
volcano. That is the biggest story. The short tip volcano is bad for side branches because it doesn't get in. So quickly review what you had done.
RO.
Yeah, just a small comment. As
Plain
CT
RO.
angio has given a lot of information, I feel in that after CT angio, antegrade choice is the first choice, because now we know where the proximal cap lies. And after locating the cap proximal to the IVUS, then dual microcatheter will help.
Give me
one wire in the branch, second wire that
CO03,
might
please.
help it.
Do you want to pass the collateral and tell us then the story why you are passing the collateral? Or
Yeah, I'll tell the story first. Okay, so yeah, I tried getting into this branch. You can see RV branch because it is very tortuous. My wire was not going there. So yeah, with this a little bit of wire is in, I was not comfortable in taking IVUS down. I tried for a couple of minutes, but it didn't work out. So then I took my wire into, this branch, almost sinoatrial branch, you can see. And this branch is completely, it's a 90 degrees. I can show you IVUS. Can you please play IVUS, please, from this branch? Yeah, you play IVUS. So this is the IVUS from this branch. We can notice, a good proximal cap, which is coming at 3 o'clock, but it is like very, brisk appearance. You can see, not that, it comes next. So, yeah. Is it playing or not playing?
It is playing.
but you have micromillimeter pullback. 0.5 millimeter pullback per second.
Yeah.
Yeah.
So
I'll
go
just play.
fast. Yeah. Little, you just, yeah, you can see here at 3 to 6 o'clock, you can see a vessel coming and, and joining. It's okay, but it's not like a gradual, and also you can see the branch which is coming and joining is also in the same direction. So that was the problem, I had. So what I did, I just thought of, wiring, with a microcatheter after removing IVUS. This is not live IVUS puncture, which I tried because even the branch is coming off the proximal cap in IVUS. I was but not comfortable and not great for IVUS guided cap puncture. So I thought of trying, just using my CT information. So I tried, wiring the middle zone. So, but the wire was just going into that branch. And as I already showed you in IVUS, both the proximal cap and the branch are sitting in the same angle, in IVUS. So
But you
tried
had
for
a
5
view.
minutes.
But you had a view where you told us that you can
Yeah, this is
delete, and you could have used a dual lumen catheter in that position to puncture right in this direction.
Yeah, so to use dual lumen catheter, from this branch, the wire is not going distally. So wire is just stuck at the bend in the vessel there. Yeah, I think that's a nice choice, but honestly, I didn't consider that option.
Okay, so you
Yeah.
go to the retrograde. Now let's show the. He can, I think, quickly pass the collateral now, and then we go to the other lab. So you have a Corsair. Corsair
This is
XS?
Turnpike LP. So
Turnpike
Turnpike
LP.
LP is placed into subtle. So now I'm taking CO03 wire. So I'm going with CO03. So my reference is same view, right? Yeah.
Yeah, the selective injection reveals that the vessel is often more tortuous than in the overview. So it's getting often more challenging. But Suo should take such turns. So comment what you do. With a heartbeat, advancing the wire on the reference and through.
Yeah.
Okay.
We crossed.
I think it's important not to push it. Wait for the systolic, diastolic relaxation. And then as far as possible.
Give me another wire connector, please. Sorry, another talker, please. Yeah. So we crossed with CO. So I think now you can see I'm at, yeah, you can see, this is the branch which I spoke about in CT. So, and the CO is just going into that branch. So let's go to LEO and confirm the course, please. Just go to LEO. Yeah, that's fine. Yeah, okay, can save. Yeah, come to RO. Now I'll take my Turnpike LP to RCA. Then I'll escalate my wire to Gaia 2. You can see, yeah, Turnpike went without much issue. So since the collateral size was quite good, so
it would be good to inject distal to see whether there might be a notch at the level of this side branch.
Okay, so once my Turnpike is there, I'll surely inject and show you. Yes, so I'm there. So
Not
now
too
just
far
give me,
into the side branch.
yeah. Wait, give me normal saline, please. Yeah. Keep Gaia 2 ready.
Any specific reason you're asking for a Gaia 2?
Even Gaia 1 can go. I have to escalate. So because in CT, this lesion, appeared just a plaque. There is no calcium at all.
Exactly.
So there was only one spot of calcium that is again, distal to the distal plaque. That's fine. No.
I think it's important to see whether there is a notch where you can aim at, or whether you have to penetrate.
So you can see it's again, ambiguous distal cap.
So it's not trivial because here you can get out as well. And I think you need to puncture. And from retrograde, I would always prefer a Gaia third because you take away the power of the wire because of the long course of the microcatheter through the heart. So a Gaia 3 is, I think, more powerful. And here you see that there will be a problem because you have no marker of your proximal cap, actually.
Two already open. Okay. Since Gaia 2 is already opened, so I'll just check my luck here.
I think we stay a little bit with you for another 3-4 minutes because that is an important step, and it's sometimes good to have a live step in a live transmission and not plural storage. As far as I know, my friend Cambis in Rome, they will have found anyway a very complex case which takes them long enough. So this is exactly what I had a presentation today about what is the problem of the switching from anti to retro. And he tried everything antigrade, but still the problem is that you have no wire marking the proximal cap, even if it would be subintimal. So now you have to blindly find a way at the distal ambiguous cap because you have no
You can
target.
see, the wire is just jumping into side branch.
Yeah.
So
You need something stiff.
Yeah, so I'll just escalate it to Gaia 3 as you suggested. If it doesn't work, then I'll move on to Harnett.
What I would even suggest is
Give me Gaia 3.
to leave the wire there and the collateral there and now try with a stiff wire to puncture antigrade, because if you don't mark the antigrade cap, your retrograde wire could go into nowhere land.
Absolutely, because we are talking about an ambiguous retrograde cap now. So we need something to guide us. So antigrade, even if we are going subintimal, we are okay. At least we'll have a track where to go.
So Sharath, we have your transmission on the side screen. So we can follow these steps, and now we go to the other cath lab if they are ready.
Sure.
Sharath, Ganesh here, we are back with you.
Oh, okay. So I'll show you what we tried. I had suggested, I think. Or this is where we left you. So first I tried Gaia 2. It is going into RV branch. Then we tried the Gaia 3. So with Gaia 3 also I had same problem, and this is Harnett 14. So Harnett 14 a little bit penetrated in the direction of distal cap. So then immediately I thought, I don't want to go with this wire. So whatever penetration or channel I created, I wanted to track with Gaia 3. So now I took Gaia 3. I'm just trying to track into that channel. So or that opening I created in distal plot. So I'm just checking my luck. Yeah, this otherwise, I'll upgrade again to
I would
maybe IJCTO.
If you don't progress, I would really go back to the antigrade part with a side lumen catheter and puncture with a conquest or a hornet that you have towards the distal wire. Because the proximal cap preparation is essential for a successful CTO like this.
Sharath, we feel that the puncture between the anterior cap versus the distal cap here, both are ambiguous.
Yes.
In the anterior cap, at least you have more control on it. While the retrograde cap, you do not have any control on it. I mean, we don't know where you're going to puncture. So what we strongly believe that leaving this wire here in the retrograde position antegrade puncture would be safer, more predictable.
Yes, yes. I take your point. So, yeah,
Sharath,
that's-
in the initial CTO, you have shown two branches coming out in the antegrade
yes.
part. Then you keep two wires there, exactly in the middle, in the same angle. If you puncture antegrade, will it give a benefit?
Yeah, I mean, that essentially, only guides in terms of course, but not exactly in the cap. So yeah, we are only making sure that our course is correct. Just give me that IJCTO wire. Yeah, right.
You even want to go to CP20?
Yeah, CP20.
It's called Astato outside of Japan, but in Japan it's Conquest Pro 820. The same wire, essentially.
Sharath, for the sake of the audience,
Yeah.
can you tell us when you're puncturing the distal cap retrogradely?
Yeah.
What are the precautions you're taking, and what is it that is giving you confidence that this is the place where you need to puncture? I mean, are there any predictors or are there any guide for you where exactly to puncture?
See, it's an ambiguous distal cap. So, I mean, I don't have any guide, but in CT, I basically noticed this is the view, where your distal cap is separating well from the side branch, and I'm just puncturing in that. It's a blind fashion. So I think there is nothing, which is guiding me here. But what is most important is I keep a track on, PVCs on the system. So if any PVC is coming, that means I am not in right place.
That is a little bit tricky because the right ventricle doesn't cause too much, or the part where you are doesn't necessarily cause PVCs. The patient may feel pain that is often more indicative of.
You can see, there are a lot of PVCs.
Okay, but you made some progress, but maybe in the other plane, be confirming the position with such a
so
stiff
just
wire.
Record this, go to LEO. Yeah, it looks in the direction of RCA. Yeah, you can record this, and exactly towards the other side of RV branch origin. Come to same RAO view, please.
Since you have already punctured, or we presume that you have punctured the distal cap, would you downsize your?
Yes, I'll do that. I just want to get little up, because otherwise, this otherwise, won't give you great support.
So how is the feel on the tip of the wire?
I have resistance, definitely.
Okay.
But looking at the CT scan with almost zero calcification there, you're in the true lumen, won't be getting so much of resistance or the beats.
So what are you doing? You are advancing your microcatheter now?
No, I'm only trying to send my wire. Now I'll take my microcatheter support. I'm pushing microcatheter as close as possible just to garner some support.
I think your tip of the wire and microcatheter length is too long. In that case, the force doesn't go into the tip of the wire. So it's very nice to put the microcatheter in. So you have to make the tip of the wire and the microcatheter relatively smaller distance to make the wire go penetration easier.
Hi Sharath, Dr. Girish here. If you think the resistance is more, would you go to a hydrophilic wire within the body to traverse a certain distance, like a Pilot 200 or something? Would you like to try?
And in such scenarios, pilot really won't give you a good support to get into cap. So once I make a way into the cap, then, I can de-escalate my wire to either Gaia or pilot or whatever. So
Now your
I have to
microcatheter is,
essentially,
yeah.
I have to essentially make a hole in the distal cap. So without that, these wires may not work.
I
So
think you must
microcatheter
have
is back
made.
again. What are
Yeah,
you
yeah.
doing? What is your plan to understand the angio?
I'm only just trying to penetrate cap and go a little bit into CTO segment. Then I'll de-escalate wide to Gaia 3.
But I thought you had already penetrated.
Yes.
Okay, Dr. Sharath,
Okay, I'll take
yeah,
Gaia
I'm
3 now.
Hamaka, and I'm agree that
Give me Gaia 3
try
now.
the integrate approach from now.
Yes.
But if
I'll
you
just try
want to-
with Gaia. Yeah, I'll
if-
de-escalate wire and try with Gaia 3. If it doesn't move, then I'm going to start my integrate again.
Yeah, if you want to strengthen the retrograde punctual strength, so it is one idea that using the double lumen catheter through the
Yes.
retrograde approach.
Yeah, we don't have that Sasuke with us. Yeah, we can mark workhorse wire and then take Sasuke and then we can puncture. So I don't have Sasuke in my lab. Yeah, so I'll just show you, I knuckled antigrade. So I can show a couple of things. You can see this knuckle, but it is going into side branches as predicted. So now what I'm doing, again, I'll just take my chance or luck on retrograde knuckle. So knuckle is just going into side branches despite
Okay, Sharath, we will leave you
yeah.
here. Please continue working and maybe
Yes.
you can bring the case tomorrow and show it to us tomorrow.
Sure.
The last part of your case.
Yeah,
Thank you so much once again
Okay.
for a very
Right, sir.
complex
Thank
case.
you.
Yeah.
Okay. So after failed cap penetration by retrograde wire and antigrade wire, despite using all escalations, we moved on to base technique. So the only option now is doing an antigrade base versus retrograde knuckle. So since retrograde is ambiguous cap, and if it perforates, it doesn't stay in my control. So we thought of going antigrade base with subintimal entry and followed by knuckle. So that is what I'm doing here. This is a 3.5 balloon, and on the side, you have a corsair. So, and we took Gaia 3 wire. We tried with Hornet 14. We also tried with Conquest Pro 20, that is IJCTO wire, but we couldn't penetrate with those wires. Finally, Gaia 3, penetrated into subintima with the balloon support. So, and you can see now, so what I'm saying, the wire codes in areocranial view to make sure that wire is within the vessel architecture. So when the wire is moving, in the same direction as retrograde wire, in two views, orthogonal views, that says it is within the vessel architecture. So once that is confirmed, so now you can see I'm just injecting and see, the wire is subintimal antigradely, which is clearly visible here. You can see the lumen and wire. So wire is clearly subintimal. So once that is confirmed, the next step is sending microcatheter into the subintimal space. So now you can see, I'm pushing my microcatheter, Corsair torqueable microcatheter into subintimal space, and you can also witness poor guide support here. But yeah, so I have to send microcatheter into subintimal space. And once it is in the subintimal space, we can again confirm with the, RAO or RAO cranial view about its advancement. You can see it is already, advanced beyond the balloon. So that clearly we can further advance it. So make sure it is in subintimal space, and once we are enough into subintimal space, then the next option is, I will knuckle. I'll take a Gladius Mongo wire and do knuckling and get across the CTO. See, the reason why I chose knuckling is, anyway, in this case, I'm facing with impenetrable distal cap as well. So even if I take, my Gaia, and because that cap is not penetratable with the Gaia, IJCTO and Conquest, sorry, 114. So that's why I felt just do knuckling and send knuckle beyond the distal cap. And you can see here now, once a microcatheter is in subintimal space, I trapped microcatheter in subintimal space with my balloon in the true lumen, and then brought Gladius wire with knuckle. So this is the knuckle of Gladius wire. So, and now we advance knuckle in both the views. We are just checking alignment in LAO as well as in RAO. So once alignment is okay, then we can advance, knuckle, beyond the distal cap. So essentially it is beyond the distal cap because cap was not penetratable, and we want to crush the cap, with the balloon dilatation, and subsequently move on to reverse cart. So that was the plan. So now you can see knuckle is just gone beyond the distal cap. So distal cap is marked by the retrograde wire. So yeah, we are beyond the distal cap, and we are clearly within the vessel architecture. So which is known by, the wire movement, both retrograde and antigrade wire movement in all the views, which is dancing with the vessel. Yeah. So once that is done, so now my next plan is obviously, I'll move on to reverse cart. So so what we'll do is we'll bring down an antigrade balloon, so like 3 millimeter balloon antigrade. To do that, I have to remove this balloon and deflate this balloon and remove microcatheter. So, and bring a 3 mm balloon on, your knuckled wire, and then start reverse cart. But it's also prudent to bring a guide extension, because there is a bend, immediately proximal to CTO. So it is prudent to bring a guide extension as well. So we used a trap liner in this case, and you can see, yeah, now there is a trap liner here, and this is a 3 millimeter balloon for reverse cart. And we tried with Gaia first, not successful. Then I enhanced it to IJCTO. Here my antigrade is in subintima, retrograde is in intima. So obviously wire has to go across the intimal flap. So that's the reason you need a a high tip load wire. So I used IJCTO as well, but I was not successful even with IJCTO. Then again, I used Gaia 3, and with the Gaia 3, so we were able to successfully do reverse card, and followed by brought the guide extension into mid RCA, and pulled this wire into guide extension. It's essentially guide extension assisted reverse card. Now you can see wire is into guide extension. It's a trap liner basically, and trap liner is moved forward into the mid RCA over the two wires, and now we are ready for externalization, and we advanced microcatheter into guide extension, followed by externalization with RG wire. And once externalization is done, so it's next is like any other regular angioplasty, so nothing great here. We just dilated entire lesion and then did an IVUS. IVUS is very important because we have to charter everything, where the wire is subintimal, where it is in true lumen distally and proximally. Based on that, we'll decide stunting strategy. So yeah, so we are just taking guide extension further down, I think, for bringing retrograde wire into antegrade trap liner. So yeah, it took a while, so it was a difficult reverse card in this case. Yeah, but finally we were successful in bringing wire, and now you can see we externalized. Yeah, this is, yeah, we went ahead with externalization, and followed by rest of the angioplasty with IVUS guidance. So as I already mentioned, IVUS is very crucial. That marks your vessel, different sides, intima, subintima, everything, and based on which will so stunt the vessel. So once stunting is done, so we are checking collateral. Collateral is, there is no damage in collateral. So we pulled retrograde system out, and you can see this is a final result with a good RCA and good distal flow. And you can also witness all the branches around except sinoatrial branch, everything is patent and flowing nicely. And then we checked donor vessel, so you can see this is fine because there was disease in donor vessel. So donor vessel is also fine. So that's the end of the procedure. Thank you.